Our next speaker is Naina Mohan, who is an acute internal obstetric medicine consultant at Kingston Hospital, who is going to speak to us about the assessment and management of asthma in pregnancy. Thanks, Naina.
Thank you very much. And can you see my slides there, Trudy? Perfect, cool. So thanks again for inviting me to come speak today. I'm Naina. I'm a physician over at Kingston Hospital, where I do quite a bit of acute medicine and quite a bit of obstetric medicine as well. And I've been tasked to talk to you today about asthma in pregnancy, which is one of my favorite topics, not going to lie. So in the next sort of 25 minutes or so, with space for questions at the end, we're going to talk about physiology, epidemiology, the effects of the asthma on pregnancy and the effects of the pregnancy on the asthma, how we go about diagnosing asthma, what sort of symptoms do we need to be on the lookout for, managing chronic asthma, and then what gets people really head up actually is managing the acute exacerbations. What are the management considerations around that quite stressful time? And then just one slide on asthma in labor. So first diving into the physiology. So your resting minute ventilation, which is the amount of air that goes in and out of your lungs at rest, goes up by about 40 to 50% towards the end of pregnancy. And that's largely progesterone driven. And this is all driven actually by your tidal volume. The tidal volume increases, but your respiratory rate stays the same, which is incredibly important to remember when you're looking after women with respiratory disease. Your functional residual capacity, which is the amount of air in your lungs after you've taken a deeper breath out as possible. There's still a little bit of air left in your lungs normally. That reduces by 20% in the third trimester as the gravid uterus comes up and starts squishing the diaphragm, essentially. Your vital capacity stays the same, which is the amount of air that you can blow in and out. You can blow out in one go, which is about 5 liters. And your FEV1, your forced expiratory volume in 1 second, and your peak expiratory flow rate stays the same. And these two are the most important things to keep in mind when you're looking after asthmatics. So the epidemiology, it's incredibly common. We will all have looked after pregnant women with asthma by this point. It affects 2 to 13% of pregnancies. It's the most common respiratory condition in pregnancy, and therefore is associated with more healthcare use and costs. So it's really important that we treat these women well and we treat this condition well. So actually, what are the effects that we're worried about? Now, classically, this paper was a prospective study and it came out with this lovely rule of a third. So asthma generally gets better in a third, it gets worse in a third, and about a third of women will have no change at all during their pregnancy. Now, what's important for us is to try and figure out which of these women are the ones that are going to get worse. Now, this was another prospective study, now quite old, nearly 20 years old, where they looked at the severity of a woman's asthma coming into the pregnancy. And they stratified it into mild, moderate, and severe based on their symptom burden, their FEV1, so the actual how much air they could blow out in 1 second, and their medication use. Was a woman taking salbutamol once every other week in the summer and nothing in the winter? Or was this woman needing sort of quite frequent courses of oral steroids to keep her asthma under control? Now, depending on the woman's asthma control and severity coming into the pregnancy, you could then predict her need to be hospitalized, to have an unscheduled visit, to need oral steroids in the pregnancy, to exacerbate and to have asthma symptoms during labor and delivery. So basically, it's the women that have got poorly controlled asthma, difficult to control asthma, the brittle asthmatics, that we need to be keeping an extra close eye on during their pregnancy. Now, with most medical conditions, if you control the asthma, you're going to have a lovely, normal, lovely pregnancy. It's not associated with adverse outcomes. The poorly controlled asthma is associated with IUGR, low birth weight, preterm birth, and preeclampsia. And we think that that is to do with transient maternal hypoxia affecting fetal development and placental function. It's also associated with GDM, particularly in the women who need repeated courses of oral steroids to control their symptoms. So that's all makes sense. So we need to control the asthma in order to have an uneventful pregnancy. So how do we go about diagnosing asthma? And there's lots of very good guidelines around. But first, let's talk about what is asthma. So the definition is reversible airflow obstruction. So where you get bronchoconstriction of your airways, that is reversible. That can get better. You need to have symptoms, more than one of wheeze, shortness of breath, chest tightness, and a cough. And generally, these will display a diurnal pattern. So as these women will come in and say, oh, my symptoms are much worse at nighttime. I'm wheezing at nighttime. I'm coughing first thing in the morning, because that's when your endogenous cortisol is at its lowest point. So that you've got less anti-inflammatory effects within the body and you didn't develop these symptoms. So this, and I'm not even going to apologize for this very simple diagram. I'm a very simple person, and this is how my brain works. So this is and I don't know, I don't have a cut. So on your left, there's a normal airway. You can see that the airway lining is the wall is nice and thin. It looks healthy. There's a nice big airway in the middle, and your smooth muscles are relaxed. In asthma, what happens is that you get infiltration of the bronchiolar wall, particularly with eosinophils. And the bronchiolar wall will get thick and inflamed looking. It'll start producing more mucus or sputum. And then in your asthmatic attacks, you will then get bronchoconstriction of your smooth muscles, causing acute exacerbations, acute shortness of breath, those acute symptoms that we're so good at dealing with. Now, this is from the NICE guidelines. It's a very complex slide, but really what I just want you to pay attention to is the first two lines. So in order to diagnose asthma, you've got a person with symptoms. So you need symptoms suggestive of asthma. You then need to do spirometry. And that's normally done in the outpatient setting with our respiratory colleagues. And you get them to blow into a spirometer, and you calculate their forced expiratory volume in 1 second and your forced vital capacity. It gives you the numbers, and you divide the two together. So you want that ratio. And if you've got a ratio of less than 0.7, that is an obstructive pattern of airflow limitation. You then want to give them salbutamol during that spirometry session, and that obstruction gets better or it goes away completely. So that's your reversible airflow obstruction. And then after that, you want to check the FeNO. And now, so the FeNO is the new kid on the block. It's what all the cool kids are playing with these days. And it's your fraction of exhaled nitric oxide. Now, this is a handheld device that our respiratory nurses and colleagues will have, and they can do them at the bedside. So if you ask them to come review your patient in maternity or the acute medical unit, they just bring it with them. And what it detects is your airway inflammation, particularly eosinophilic airway inflammation, which I explained before is classical for asthma. Those eosinophils will produce nitric oxide as part of their metabolic processes. And then you measure the fraction of exhaled nitric oxide in the woman's breath as an indirect marker of your airway inflammation. And this has got positive predictive value of 0.7 and has been validated in pregnancy as well. So a value of 40 parts per billion or above is positive and indicative of airway inflammation. So essentially, after all of that, if a woman comes to you and says, I've been coughing, I've been breathless, I've been wheezing at night, every time I exercise, I have to stop because I get so breathless and I get really wheezy and tight-chested, you want to take a good history and examine the patient. You want to check their FeNO, either by getting the respiratory team over to you or sending the woman to the respiratory team. You want to request spirometry, and normally on the form, it'll say, do you want bronchodilator reversibility? You tick that yes, because you want to make sure that there's that reversible airway obstruction. Please request a chest x-ray for all of these women. You want to make sure that you're not missing something else like a chest infection or fibrosis or other weird and wonderful things that these women might have. And then refer them on either to your obstetric physician or to your respiratory colleagues who can provide some support. So managing chronic asthma. Coming back to my very simple diagram. So the pathophysiology in asthma is the thickened, inflamed bronchiolar walls and your bronchoconstriction. So the drugs that we have treat those. So starting here at the top right, we've got the long-acting beta agonists, which are your formoterols, particularly found in something like Foster. Your short-acting beta agonists, like your salbutamol, and your montelukast, which are your leukotriene receptor antagonists. Those are bronchodilators, and that's how they are used in the treatment of asthma. They bronchodilate. So they relax those smooth muscles. Down at the bottom right here, we've got long-acting muscarinic antagonists. Those are your tiotropiums, your ipratropiums, and those have a dual action. So they do have a bronchodilator effect, but they also work on airway inflammation and reducing that, and particularly reducing the amount of mucus or sputum that these inflamed airways are producing. So that's where that sits. And then your inhaled or oral corticosteroids. So that's your formoterol, which is in your Foster, or your budesonide, which is in your, steroid, inhaled steroid only, or your oral corticosteroids, your prednisones. Those act on your airway inflammation. So that helps to reduce that inflammation and reduce that eosinophilic infiltration of your bronchiolar walls. And these therapies are all in this BTS guideline. So it's a stepwise, a step ladder essentially in how you treat these women. So if you've got symptoms, the first thing you want to do is give a low dose inhaled corticosteroid. And in blue underneath here, this regular preventer, in blue are written what we would use in this sector. So over here we'd use beclomethasone, and that's your brown inhaler. So the woman would be on the brown inhaler and the blue inhaler and be going about her life. Now, if she's still having symptoms, still needing more than 3 doses of salbutamol a week, you go up the ladder. So your initial add-on therapy is to add in a long-acting beta agonist to the low-dose inhaled corticosteroid. Now, in the sector, we love Foster. I love Foster. It's such a great drug. Now, the Foster 100/6, the 100 is the dose of the steroid, the budesonide. And the 6 is the dose of the formoterol. So the 6 doesn't change. The formoterol stays the same, but you can go up and down in your steroid dose. So the 100 is the lowest dose of the inhaled steroid in Foster that we can give. And you can ask the woman to take 1 to 2 puffs BD. It's a BD dosing. Now, this thing marked down here, so maintenance and reliever therapy. Formoterol, Foster in particular, you can ask some women to use that both as their reliever and their preventer. So they take it twice a day, morning and night, the 100/6 preparation. And if they have any symptoms, whereas before you'd ask the woman to reach for her blue inhaler, you can ask them to just keep using the Foster. And they can take up to 8 puffs in one go. And it's been used in trials. It's got very good evidence for its use. But obviously, you and me wouldn't be, well, I might do, but the respiratory team really should be leading on asking women and educating women about MART therapy. So let's just leave that to the side for now. We're more interested in the LABA plus ICS. So if the woman is still needing symptom control, you then increase the dose of the inhaled corticosteroid to the 200/6. Or you can consider adding in the leukotriene receptor antagonist, which is your montelukast. And then after that, I would be referring to the Brompton or to our respiratory colleagues to try and initiate other therapy if we're still not getting symptom control. So like I spend most of my time in clinic, as do you, I imagine, counseling women that these medications are safe. All of the medications used in asthma are safe, thankfully, which makes my life very easy. But these women, the women that we're looking after, do not necessarily know that or understand that and need to be reassured. So this was a paper from 2011, and they surveyed women about whether they felt that their medications that they were using for the asthma was going to harm their baby. 42% said yes for oral steroids, 12% said yes for inhaled corticosteroids, and 5% for salbutamol. So obviously that's something that we need to be reviewing at every interaction with these women to make sure that, yes, they're taking their medications and that they understand that it is safe. Interestingly, and what this paper didn't look at is actually surveying healthcare professionals, because some of my medical colleagues, I imagine some of them also have a sort of similar perceived teratogenic risk as well. So I will often get calls from my A&E colleagues saying, "Oh, is it okay to give the woman this?" Yes, it is. Give her whatever she needs. So just quickly about the other medications that we might use. So montelukast is your leukotriene receptor antagonist. And there's reassuring animal data. I mean, and that's sometimes the best that we can get in pregnancy, isn't it? No one's done the randomized control trial looking at montelukast in pregnancy. But reassuringly, we've been using it for a number of years now, and there's been no evidence of major congenital malformations in humans. Theophylline has sort of fallen by the wayside. When I was a registrar 5-6 years ago, we used to use it quite a lot in our asthma exacerbations and in the use of our chronic asthmas, but it's fallen. We don't really use it much anymore. But if you did, if I was in a sort of sticky corner and I was just needing to bide some time, I might think about some theophylline. And again, it's safe in pregnancy. And then now the biologics, I mean, name me a condition that we don't treat with biologics. So omalizumab, mepolizumab's on the market now as well. We think that they are safe. There's been no adverse risks reported. As with any biologic therapy, you just ask the woman if she was using it in the third trimester to delay the use of the BCG vaccine. But really, if the woman has got asthma severe enough to need biologics, I would advocate that she needs it all the way through her pregnancy, and that she just needs to be counseled about that. Now, inhaler technique. I have seen patients, not just pregnant, not particularly pregnant women, but patients of all shapes, sizes, genders. Their inhaler technique, they do all sorts with their inhalers. I've seen people shake it and puff it by the ear before then puffing it, or it's wild what some people might do with their inhalers. Now, these DPIs on the left here, which is the QVAR, the one that you have to shake and then press the button and coordinate that with your breath in, I would find that particularly tricky to do, as do our patients. Now, especially if you're having an asthma exacerbation, your hands are shaking because you've already had 5 doses of salbutamol, you're trying to take another puff. How are you meant to coordinate those two things, the puff with the inhalation? So the gold standard is that the dry powdered inhalers need to be prescribed with a spacer device, just to increase that drug delivery to the airways and make it easier for our patients. On the right, though, is the Nexthaler. So that's your metered dose inhaler. And I found that much more helpful. And I prefer prescribing that, particularly for our fosters. So you just basically open up the lid like that. And the dose is triggered by your inhalation. So you just need to tell the woman that you need to take a short, sharp breath. So, and that is enough to deliver the dose to the right place. And often a lot of our women will be absolutely fine with that. If a woman comes up to you and she shows you an inhaler that you've never seen before, I've seen inhalers that you have to press buttons and twist things and put in doses. It can be very confusing. This website, rightbreathe.com, has got a video of how to deliver inhaler technique for all of the inhalers on the market. It's an incredibly useful resource. Now, if you're thinking about chronic asthma and a woman's got symptoms and you're escalating treatment, she's not really getting much better, don't forget about these 3 things. So rhinitis will have similar sort of symptoms. So can give you a cough, can give you chest tightness. Make sure that you're treating hay fever, essentially. Okay, so your steroid nasal sprays, your antihistamines, all of that are safe. Make sure that she's having those as well if she needs them. GORD as well. So your reflux disease, particularly with the nighttime cough, though that can really overlap with asthma as well. So make sure you're treating that effectively. So your meprozols and your Gaviscons, all of those. Smoking cessation obviously is incredibly important in this group of patients as well. And if the woman's continuing to smoke, her asthma is just not going to get controlled. So acute exacerbations of asthma. So the classification here. So when a woman comes in and she's breathless, the first thing you need to do is set of obs and check the peak flow. If the peak flow is 50 to 75% best predicted, that's moderate asthma. Acute severe asthma has got a peak flow of 33 to 50%, a respiratory rate above 25. The heart rate, I would maybe leave by the wayside because we know that pregnant women can have a heart rate up to 110 in normal pregnancy. And if she's unable to complete sentences in one breath, that's acute severe asthma. And in life-threatening asthma, a peak flow less than 33%, hypoxia, silent chest, poor respiratory effort, arrhythmia. I mean, we don't really need a classification. We know that's all life-threatening. Now, if a woman comes in and she's a bit breathless and her peak flow is 65, 70% of her best or predicted. You give her one salbutamol nebulizer and it's back up to above 75% and she's symptomatically better. You could get her out of hospital. So you could discharge her with prednisolone 40 milligrams and with follow-up. So she needs to see a member of the respiratory team, whether that's the asthma nurse or her GP nurse. Otherwise, most of these patients need to be admitted. So we want to give targeted oxygen therapy. You want to aim SATs of 94 to 98%. Nebulizers, salbutamol, 2.5 milligrams QDS, and prescribe it PRN as well, just so that the nurse or the midwife at the bedside can keep giving it if the woman is symptomatic. Ipratropium bromide, so that is your long-acting muscarinic antagonist, so your 500 micrograms QDS. Then you need to give some steroids, so prednisolone or IV hydrocortisone. If the woman has an oral route available to her, then give her the prednisolone. If she's got life-threatening or acute severe asthma, I would just give hydrocortisone for that first dose, just so you know that the steroids are on board. Now, a single dose of MAG Self is a very good bronchodilator. We use it very often in adult medicine across in the non-pregnancy side, and obviously it's a much lower dose than what you're used to giving in maternity. And give antibiotics if there's evidence of infection. So if she's had a temperature or a cough productive of yellow sputum or the inflammatory markers are raised. Steroids are incredibly important. So these are the two papers. This is not pregnancy specific. This is why we harp on about steroids and asthma in asthma exacerbations till the cows come home, because we know that if we give steroids in a timely fashion, we reduce your admission rates, and the number needed to treat is 8. And 5 days of steroids reduces the number of relapses, hospitalizations, and the use of bronchodilators as well. So give your steroids early and give them for at least 5 days. If this is her second or third course of steroids in the last 3 months, that might be an indication that she needs a longer weaning course, in which case you would give her 40 milligrams and then maybe ask her to reduce it by 5 milligrams every week. Just be aware of the GDM risk in these women. So they may need a period of home blood glucose monitoring or an OGTT, depending on your hospital policy. So when can you send these women home? Now, if you've admitted a woman with an asthma exacerbation and her peak flow is above 75% best or predicted, you want to stop the nebulizers at that point. And she needs to be off the nebulizers for 24 hours with a stable peak flow. It still needs to be above 75% best and predicted. That is the point at which you can send her home. She needs a 5-day course of prednisolone, 40 milligrams at least. She needs to be reviewed by the asthma nurse prior to discharge, because there's an asthma bundle that we get money for and paid for as a trust, and all trusts will have this. And she needs, theoretically, she needs to follow up with a GP within 2 days and the medical team within 1 month. I don't know how realistic that is to aim for, but obviously she needs some sort of follow-up. Thankfully, asthma in labor is incredibly, incredibly rare. And that's because you've got such high rates of endogenous steroids, cortisol during labor and delivery that these women are auto bronchodilating themselves. Make sure that you continue the usual inhalers in labor, and oral sort of inhaled salbutamol will not delay labor, will not impair contractions. Ergometrin is interesting. So ergometrin in the used with GAs can cause bronchoconstriction in some cases. So the anesthetist might be a bit careful about it. But when you give it with oxytocin, it does not have that bronchoconstrictory effect. So make sure you give the Synto if you're worried about PPH or if you're treating PPH. As a rule, your prostaglandins are bronchodilators, but the prostaglandin F2 alpha, carbapenem/hemobate, can cause bronchospasm and is contraindicated in the treatment of PPH in women with asthma. Now, if I have enthralled you with asthma and you think that you need to read a little bit more, so the SIGN guidelines is the Scottish guidelines on the management of asthma, and then the British guideline on the management of asthma has got a section on asthma in pregnancy. They're very good to read, just to brush up a little bit. And any questions?
Oh, thanks so much, Naina. That was an excellent presentation. We haven't got any questions in the chat, but a question from me. Once we do a baseline peak flow measurement in pregnancy, for instance, a lady who's disclose moderate asthma, could do a peak flow measurement at booking as a baseline. Obviously, we would repeat that if she's showing any changing symptoms. But do you think, as a standard, it would be useful to check peak flow each trimester, for instance?
So what we do is we check at Kingston, at least we check a peak flow at every hospital appointment, just to make
Okay.
sure we take a history, we make sure that the symptoms are under control, and we will check a peak flow as well. So therefore, you've got the symptoms as well as the number, sort of to reassure you that the asthma is under control. But that's my practice. I don't think there's any guidelines mandating this, but I just think that it's the safest way to look after these women.
Yeah. Yeah. So essentially, a good baseline, a preconception baseline, and a surveillance serial peak flows through the pregnancy. Yeah. Yeah.
Absolutely.
And
Yeah.
then at what point at Kingston would you refer a lady to the maternal medicine centre? When would you feel that they'd move into a maternal medicine category C?
So we look after women on biologics for the asthma, and we're safe to do that because we've got a very good respiratory team, a very experienced respiratory team that provide us with support. I think if we were getting to the point where, despite the biologic, despite repeated courses of steroids, we would then potentially get some advice from the maternal medicine center, but particularly it'll be from their respiratory center, so from the Brompton, they would be the ones giving more support. But if the woman had got unstable asthma all the way through the pregnancy, we were worried about, her management or anything, then we would, there would always be those routes to get advice from. But we're normally quite happy managing these women at Kingston.
Yeah, yeah, that's really helpful. So I guess it's important for each of the midwives and the teams to understand what services they have within their own trust. Particularly for midwives who are new to the sort of maternal medicine area, knowing what specialists we're working alongside. Good. Okay. Thanks so much, Naina. Really appreciate your time today. Thanks for an excellent presentation. And that will
You're
be
very welcome.
recorded for access for everyone, even for those who haven't been able to attend today. So many thanks.
Not a problem. My pleasure.